Greetings, Dr. Mark Winton here from the University of Central Florida Department of Criminal Justice, and this is a video for the course CCJ 6617, Mental Disorders, Crime, and Criminal Justice. So first I'd like to welcome you all to the course. I will be making some videos throughout the semester and posting those for you, and they'll be in the weekly announcements, the links to the videos. Often there will be a corresponding PowerPoint that goes along with the video, and that will be posted as well on our home page. So this is becoming a more popular course. It was a much needed course, and I developed this course a number of years ago and have taught it several times at the graduate level. In this video, I'd like to just mention a few things about the course and then talk a little bit about epidemiology and diagnosis. As far as the textbook goes, we have a reader that we're using, the Criminalization of Mental Illness Reader, edited by Kelly Frayling and Risden and Slate. This goes along with a larger textbook that is in the process of being revised, and so I wanted to go ahead and use this reader this round, and it has a lot of useful information in there and a variety of information on topics of interest to criminal justice professionals. And it's relatively shorter textbook, and it will be supplemented with other readings, which I'll also post in the announcements, either the links or the information, and you'll find that on the home page. You can review the syllabus and see the assignments when they're due, and I'll also have the information about the assignments posted on the home page as well, and communicate with announcements on that within the web course. If you've taken any web course with me before, my thought process hasn't changed too much. And so, not really my thought process, but the way I organize my course, I've kept it pretty much the same. So always, if you have any questions, send me an email right away. I check my email box, I don't know, 6, 7, 8, 9 times a day, usually early in the morning, and then into the evening. So what is a mental disorder? And there's all kinds of ideas and debates about this. Is it a deviation from the norm? Is it a medical condition? Is it a thought disorder or a behavioral disorder or a disorder of affect or feelings? Or is it a combination of factors? So the first thing we run into is definitions of mental disorder. And then we begin to ask ourselves, well, what would be considered a mental disorder specific scenario? And I listed a few with the question, is this a mental disorder? Caffeine dependence, nicotine dependence, gambling addiction, sex addiction, child physical abuse, problematic PMS, are those considered mental disorders or not? And you may get the answers to those questions later on in the semester. And as far as diagnosing goes, my goal is not to teach you to diagnose people. That, of course, would be left for the psychologists, counselors, and social workers and psychiatrists. But my goal is to introduce you to some of the major mental disorders. And what we're currently using is the Dsm Ii. This is the desk reference to the diagnostic criteria for mental disorders, the 5th edition. The whole thing here that I wanted to mention is that the regular textbook is over 1,000 pages long and quite detailed. You have access to the Dsm-5 through the UCF library online. You can check it out for the day, review it. You can download a limited number of pages from there for your use later on. So, I mean, you have access to that. It's an expensive book. if you were to purchase it, and heavy, as we'll see with some of the older editions that I've collected throughout the years. So if we look in the DSM-5, which was published in 2013 by the American Psychiatric Association, here are some of the major categories we see: neurodevelopmental disorders, schizophrenia spectrum and other psychotic disorders, bipolar and related disorders, depressive disorders, anxiety disorders, obsessive compulsive and other related disorders, trauma and stressor related disorders, dissociative disorders, somatic symptom and related disorders, feeding and eating disorders, elimination disorders, sleep-wake disorders, sexual dysfunctions, gender dysphoria, disruptive impulse control and conduct disorder, substance-related and addictive disorders, neurocognitive disorders, personality disorders, paraphilic disorders, other mental disorders. Whew, I thought I could do that in one breath. Medication-induced movement disorders and other adverse effects of medication, and other conditions that may be the focus of clinical attention. So there's well over 300 plus different diagnoses when you actually have a bunch of subcategories in those that will focus some more attention on ones where they may actually be more related to criminal justice system, or they may actually sometimes fall, they may be illegal. Obviously, pedophilic disorder, exhibitionism, voyeurism, that gets into the realm of the criminal justice dimension. So if we look at the history of the Diagnostic and Statistical Manual of Mental Disorders, Dsm Ii had 106 disorders, and I don't have a copy of Dsm I with me right now. I actually have it somewhere on as a PDF file, but it's relatively short. Then the Dsm II increased to 182. Here is the actual Dsm II, and this was published in 1968. Here's my copy. Not very big, is it? I picked this up at a used bookstore, I believe, when I was in graduate school in Connecticut, at University of Connecticut. And I did a lot of research on the history of particular mental disorders and changes over time, and so I studied the DSM for that. But here's the DSM II. Dsm III, it increased to 265. Here's the pocket guide. Again, the regular book is much larger. Now I'm going to tell you how old I am. This is what I was trained on. I was trained on Dsm III in the mid-'80s when I went through my counseling training. So, if I'm at a mental health conference and say, how long you been in the field? I'll say, since Dsm III. Dsm III-R increased to 292. This one was compliments of a pharmaceutical company. Don't see that anymore. Dsm-4, so now we're getting to 300 plus mental disorders. And then Dsm-4-TR, the text revision. And then, as I mentioned, Dsm-5. I just happen to have the Dsm-4-TR text revision. This is the one that was before the Dsm-5, and you can see Dsm-4-TR, Dsm-2. You can see some big changes there, especially on price. Wow, these things are expensive. But as I mentioned, it's great. Our library is just wonderful. There's so much you can get there inside of the library, including coffee and pastries. And also the online library is just amazing. Our librarians are amazing. If you have any questions, you can contact them. They're always there to help you out. I've started using the UCF library in 1982, and it has continued to impress me. So just a wonderful, place, all kinds of resources. Sometimes you can get hundreds of books in PDF format, and download those as well. Thousands of articles from journals, doing literature searches for papers, things of that nature. So anyway, great, a great library. Just I'm very impressed and very happy we have such a wonderful facility and wonderful people working there. Okay, back to DSM. There's still much debate on what should have been included and wasn't included, and that's why in the beginning I said, are those sometimes, and you'll find at the end of DSMs you'll find sections of topics for further study, and there's lots of debate. Do you put that in there? Do you not? Or might it be? And so and of course there's some particular purposes for the Diagnostic and Statistical Manual of Mental Disorders. And Kirk and Kuchins in 1992 wrote a book about this, and they have 5 major purposes that I want to mention. First of all, regulating client flow. One of the things that we'll realize right away in the field is that a lot of people who get into the field specialize in diagnosing and treating specific disorders. So, for example, when I worked in mental health clinics, there were certain disorders that I would treat, and there are certain disorders that I would refer. A lot of cases that would come in, a lot of times I would do initial intakes for practice. And I worked in practices that had psychologists, psychiatrists, social workers, counselors, marriage and family therapists, and do intake and often then determine what would be the best therapist or situation. For example, I remember I had this guy comes in, and I do the assessment, and it's clear that he has a dependence on cocaine. I'm referring him to a substance abuse treatment center, and then we'll work with him later, but he needs to get his substance use issue dealt with first. Or for example, I had someone that comes in, and I think maybe they might have an eating disorder. That's something I don't have that much knowledge on. I have enough knowledge to refer them to a colleague who specializes in eating disorders. So I work with a lot of cases that involve violence and also paraphilic behaviors, sexual deviations, sexual dysfunctions. So I work with a lot of those cases over the years when I was a counselor. So the second purpose is protecting clients from harm. So we also want to know how the diagnosis is connected to risk, and we'll talk about that later on. And that's certainly something relevant in the criminal justice system. You're always interested in doing some kind of risk assessment or assessing risk, certainly for safety purposes, but also liability purposes. And then the third is acquiring physical resources. It's no secret that someone gets diagnosed, that information gets sent often to an insurance company for reimbursement. And the fourth is rationalizing decision making. Why did I decide to do this? Well, if a person has particular diagnoses, then there's a rationale for specific treatment, whether inpatient, outpatient, group, substance abuse, whatever the case might be. And then the fifth is advancing political agendas. And so like every profession, you have lobbyists, you have conflicts, you have within the profession, between different professionals. It was a long time before the licensed mental health counselors were able to Baker Act, because there's a lot of infighting with the different groups. And so this is something that is ongoing, and it's also very political, what would be considered to be a mental disorder and what would considered to be not. That there's actually been cases where we've seen certain things, certain conditions that are included or not included, or included at some DSM and then removed later on. So there's a lot of politics behind that. We'll also be looking at some theories of mental disorders, and just in a nutshell, we kind of get into biological, psychological, and sociological. And then just to really just quickly summarize: genetic, biochemical, behavioral, cognitive, psychoanalytic, structural, functional, conflict, symbolic interaction, family systems, and then combination. And that's just a few. There's literally all kinds of treatments. I think what you're going to find, though, is that the cognitive behavioral is pretty popular in use in the criminal justice system, family therapy also, and also the use of medications to treat mental disorders is very popular as well. Okay. Also, we'll be looking at the epidemiology. How much mental disorders are there, and specific types of mental disorders, and who seems to have higher and lower rates, and what are the distributions in populations and in demographic aspects. And so we get into the epidemiology. The incidence is the number of new cases during a specified period of time, and the prevalence is the total number of cases in a given population. So you'll see that. And I have an example, the Kessler et al. National Comorbidity Study. So that was a huge study. The one I have up here really was published a while back in 1994, but that really was considered to be a major advance in epidemiological studies of mental disorders. They took a random sample of 15 to 54-year-olds in the non-institutionalized population. It had a sample over 8,000. They used a diagnostic interview, so they had consistency for reliability and validity checks. And the research has been updated and many papers have been published, but just going back to the original, they found that, and this is real important, that 79% of those mental disorders were comorbid for lifetime disorders. In other words, they had more than one disorder. So that's something we're going to see in the field. We're going to see comorbidity, that it is not unusual to have multiple mental disorders going on. We may focus on a primary one. Back to that guy I was telling you about, who I sent to the Substance Abuse Treatment Center for his cocaine abuse, also was depressed. So that's something that would have to be worked on as well. But it's kind of hard to work on that depression with the cocaine going on. And so sometimes we see that a lot with substance use disorders. There's other things going on, but often we need to help stop the substance use first, and then we can deal more effectively with other mental disorders. We find some gender differences there. We find some age factors that are relevant, socioeconomic status, also regional differences. And so I have a couple summaries there where I look at lifetime and the 12-month. For example, looking at depression, they found 17% would be diagnosed with depression over the lifetime, and the 12-month snapshot basically in that given year, 10%. That's relatively high rate. Alcohol dependence, 14% lifetime, 12-month, 7%. And some have argued that that these are kind of overestimates, that when they argue that the rates certainly of severe mental disorders are much lower in that regard. Basically, when you look at total, 48% over the lifetime people had a mental disorder, and a 12-month snapshot, 29%. So that's a relatively large amount, almost for the lifetime, half the population, and a good 1/3 at any one particular time. But again, we have to look at the dimensions. We have to look at things such as severity, different types, and all this becomes extremely important. Anxiety disorder is relatively common as well. So is substance use disorders. Antisocial personality disorder, what I have down there is APD, is an interesting one to study from the criminal justice perspective, because we'll start looking at that. That's really related to what is not in the DSM, but when we talk about psychopathy, the psychopaths, sociopaths, those are not diagnostic categories from the DSM, but antisocial personality disorder among adults and conduct disorder among children are include behaviors that may be inconsistent with the legal system following particular laws. And so I have a slide with the antisocial personality disorder, just giving a couple of, looking at some of the epidemiological aspects of that. So that, I think, kind of sums up what I wanted to do, and then we'll read some articles on more specific mental disorders and also on the epidemiology. We're also very interested in looking at the epidemiological studies in the criminal justice system, also in the correctional system, and this can be helpful too, because we have to think about prevention, we have to think about interventions, treatment, we have to think about post release, for example, what kind of interventions and treatment, that we really have a lot more work to do with the criminal justice system and mental disorders, really a lot. Let me just give you a brief background of my experience and education, maybe real quickly, but I received my bachelor's degree in psychology from the University of Central Florida back in 1984, and then I went on and got a master's degree in counseling at Rollins College, and then a master's degree in applied sociology at University of Central Florida. And I went on and I received a PhD in sociology at the University of Connecticut. I did practice as a counselor in private practice in public mental health center. I did a lot of work working in a child abuse and neglect field, and also with working in the area of sex crimes and working closely with the criminal justice system, law enforcement. I've never been a law enforcement officer before, but I worked closely with cases. I went to court a lot, testified, wrote case plans, evaluated people, and also supervised a treatment program, and also worked in group therapy with adolescents, some who are involved with the criminal justice system. And so in my early years, I worked as a counselor, and then I retired from that and really went into teaching and research full time. And most of my research in the last 10 years or so has been focused on genocide and torture and violent behavior. And so I've kind of put all this together. For example, I might be interested in looking at mental disorder in cases of genocide, different types, post-traumatic stress among survivors of genocide. And so there's still a lot of the relationships there with the criminal justice system, obviously. I've been teaching at UCF for 31 years now. And so not only do I have 2 degrees from UCF, but I also have been teaching there for 31 years. 10 years I started with the sociology department, then 21 years ago I moved over to the criminal justice department. And been very happy at UCF and hope to continue for a number of years into the future, continuing to teach and also conduct research. So I'll try to keep these not too long. I almost got to 25 minutes here, so I'm going to welcome you all to the course and wish you all well, and I'll see you online.